Good morning, everyone. Let's convene, shall we? It's 9 o'clock. We have a full day ahead of us. I'm Dr. John Ward. I'm the Director of the Division of Viral Hepatitis. It's my pleasure to welcome you to CDC. I see a number of familiar faces in the audience, in part because many of them work in my division, so it should be no surprise. But then also among our guests, it's great to have you here. A number of you have hosted me at your institutions, and it's really a pleasure to be able to do so today and tomorrow here at CDC. It's also my pleasure to introduce Dr. Jonathan Merman, who's the director of our Center for HIV/AIDS, Viral Hepatitis, STD, and TB prevention, and he'll be giving some opening remarks to kick us off. Thank you.
Great. Well, good morning, and thanks, John. I knew that this meeting was special when I arrived and actually saw food and beverage outside. Because as those of you who've worked with the federal government know, that meant that there was some devotees in the division who actually spent their money to provide a kind of a welcoming feast for you. And it did remind me that the disadvantage is that instead of most meetings at CDC, you're not going to lose weight while you actually attend them. But it is a reflection of kind of the real energy that's currently in place here for hepatitis, and the work that the organizing committee put in was really quite extraordinary. Particularly because when you look at the list of people speaking, it's a tremendous group that has a lot to say about important issues. And I wanted to thank John Ward and Salim Kamili for helping to organize from our group, as well as Ann Gaynor from the Association of Public Health Laboratories and Claudia Denkinger from FIND. And then I also wanted to thank our lab. I've spent a fair amount of time with the Division of Viral Hepatitis Laboratories learning about the quandaries for diagnostics and phylogenetics with hepatitis. And I think they're at the cutting edge of advanced molecular detection, as well as thinking about how this can be useful in practice, not just in kind of academic theory. And we're seeing already some of the outcomes of that in how we respond to some of our outbreaks, and also looking at transmission patterns in the United States. But it also lays the groundwork for some of the problems that we have with being able to do diagnostics for hepatitis. I think everyone here knows that hepatitis is a tremendous problem in the world and in the United States. There are about 130 million people living with HCV, and about 700,000 people who die each year from complications from that infection. However, globally, only about 6% of people know that they have hepatitis C, and in the US, where there are 3.5 million people with HCV, only about half are aware that they're infected. It's our job to help all these people know that they have the infection, get treatment as soon as possible to prevent what is increasingly being seen as complications related to the infection. You know, at least a third of people are going to die of their infection untreated, but the more we look, the more we see more complications, not just hepatic, but also extrahepatic complications. And I think that the fact that such a high proportion of people don't know that they're infected with hepatitis, as well as not having access to curative therapy, is a preventable tragedy. And it's really one of our major public health injustices of our time. So in the US, even a modest increase in the capacity to implement HCV testing for all persons who were born between 1945 and 1965 could avert more than 300,000 deaths when testing is linked to curative therapy. None of us are going to do this alone. We need devoted people from multiple disciplines. And the diversity of people in this room and among all our colleagues throughout the country and the world who are working in hepatitis, whether it's academia, public health, community organizations, and industry, really underscores the importance of the cross-sectorial collaborations that's necessary if we're going to develop and implement the technologies necessary to diagnose all of these people rapidly and effectively. I really do believe that screening for hepatitis C should be a normative part of medical care. It's not a difficult radical or complex issue when to get screened for lipids or to have your hemoglobin A1C or glucose checked once every 5 years. It's continually striking to me that the concept that we have routine screening for hepatitis is not being implemented, and that's something that people want to avoid or are reluctant to do. It's not acceptable. And I think some of what we need to do is change the practices of systems, healthcare systems, as well as clinicians, and encourage people throughout the country and the world to actually ask for testing. But we need to be able to support both the systems and the people to be able to get that done, and to make it so that ultimately the people are not seeing the obstacles that are preventing them from getting tested, but actually it's just a routine situation and it's expected that this is something that's going to happen. To do this, we are going to need to improve our technology. We need to have rapid fingerstick and oral diagnostics, as well as direct antigen and antibody diagnostics. And ultimately, we're going to need to figure out how we can get antigen tested inexpensively and accurately, both inside and outside the health care setting. I think that we're doing this for all the people who have chronic hepatitis C and are getting complications and dying, as John Ward highlights in almost every talk. Currently, there are more people in the United States dying of hepatitis C infection than all other reportable infectious diseases combined. That's not the way it should be, and it's certainly not inevitable. But to prevent that, we need to implement the screening that we've recommended. And we're doing that at the same time that we have a growing acute hepatitis C epidemic in the United States among drug injectors. And people who use drugs are a growing number and proportion of the population in the U.S., and it's at this point the epidemiology and surveillance information is limited about exactly what's happening, but we can see where it's happening. We can predict places where the public health system needs to examine more carefully to see if we need to put in interventions. We know what to do to prevent hepatitis C and to help people who inject drugs either get into medication-assisted therapy, to access sterile injection equipment, and to get diagnosed with hepatitis and treated, but it's not being done very frequently. And that's a challenge for all of us because that's going on at the same time that we have the baby boomer population increasingly getting ill. So I think in general, I see hepatitis C in particular and viral hepatitis in total as kind of a field of contrasts. There's tremendous public health urgency, yet there's minimal public health infrastructure and resources. There are remarkably effective medication and good quality diagnostics, yet a minority of people have been diagnosed and a tiny proportion cured of their infection. And it'll be our job to change this situation and for this summit to lay down a roadmap for the essential diagnostics that we will need in the near future. So I'm grateful for all of you participating and for working together on what I think is one of the great infectious disease challenges of the decade. Thank you.
Thanks, Jono. Let me just have a few kickoff remarks here to get us going in more, and by looking over the agenda. First of all, I think we're all here because we all share the same vision and goal, and that is that every person at risk for hepatitis C should have access to testing, and those that are found to be infected with hepatitis C have access to care services and treatment that leads to cure of their infection, reducing their risk of morbidity and mortality, and also the other interventions that can prevent transmission to others. That's a big priority for us. We feel like testing is very important. We've had 4 summits at CDC concerning different aspects of HCV prevention. 2 of those have been discussing hepatitis C specifically and in depth. The last one was in December of 2011, and there's a number of you in the room who also attended that meeting where We also looked at different aspects of testing, how it was being conducted, how we could help in that conduct, as well as what were technologies that were being available. Now, since 2011, we're in a much different place, some to the positive and some of real concern. To the positive, we have national policies now for hepatitis C testing that were not available in 2011. CDC recommended the birth cohort strategy, one-time testing for persons born during 1945 through 1965. A year later, that was put out in 2012. A year later, the U.S. Preventive Services Task Force joined with CDC in that recommendation, as well as reinforcing the other risk-based strategies that were previously put in place by CDC, as well as identifying a few other key populations for testing, such as those in incarcerated settings. So as far as national policies, we're in a much better place. The other positive outcome has been the implementation in many states of the Affordable Care Act, which helped remove cost as a barrier to testing, at least in many provider systems where they follow the USPSTF criteria of a Category B being reimbursed as a no copay preventive service. So people should not have to pay for hepatitis C testing in many instances. So that's been a great help. Also in 2011, in December of 2011, we were really at the dawn of the oral era for HCV therapy, with the first generation of medications being licensed about 6 months prior to that meeting. Also in 2011 was the FDA approval of the point-of-care assay for HCV testing, which provided new options for expanding access. And the use of that technology for testing continues to this day, and we'll be hearing more about that at this meeting. Also, the newest generations of those HCV therapies are now licensed by the FDA. They are even better than the first generation, safer, more effective. We now have pan-genotypic therapies, which really add to the benefits of testing. Also, the positive, we have found evidence, and you'll be seeing some of that during the meeting today, that testing has indeed improved, that there have been increases in testing of populations such as the birth cohort, as well as populations at risk. And you'll be hearing of some strategies that have made that effective. However, we know that there are real challenges, as Jono has already highlighted. Half the people in the U.S. don't know their status who are living with hep C infection. Of those that have been tested with the first test for HCV antibody, a large proportion do not receive that critical second test to diagnose whether they have current infection or have resolved that infection. And so we need to return today and tomorrow to talk about how we can improve this situation. Now, one outcome of the 2011 summit was the updating of the CDC algorithm for testing, which was published in May of 2013, which shifted the emphasis away from a confirmation of antibody positivity toward the detection of current HCV infection. And that's our current algorithm. And we're going to be hearing, particularly beginning with this first session, of how well that testing algorithm is working in various clinical settings, what can be done to improve that algorithm. Should we be thinking of new algorithms for special populations and special circumstances? As more and more people get treated and successfully cured, the antibody test becomes less and less useful, increasing the importance of frontline virologic testing, particularly important for populations with ongoing risk for infection, such as persons who inject drugs. And we're going to be examining that. Now, the agenda is very much focused on how testing is conducted in clinical settings and other care settings, as well as how laboratory procedures within major laboratories. And we'll be hearing from commercial laboratories about how those procedures are working, some strategies to improve testing effectiveness, such as reflex testing, and other strategies that they'll be highlighting. Now, in both of those sessions, looking at clinical testing as well as commercial laboratory testing, we'll be hearing about how data is being used by CDC and our public health colleagues at the state and local level to monitor the burden of disease, detect emerging trends in transmission, and to monitor the implementation of our testing recommendations. Very, very important for us to have as effective as possible case surveillance, as well as access to electronic data to serve those public health aims. We also recognize that new technologies can help us improve testing, and we're going to have a session to look at different options for making the current technologies more widely available at the primary care level, point of care level, outreach to syringe service programs and other settings, as well as what other new technologies are in development that could help us do a better job of expanding access to the testing necessary to detect current infection. The other aspect that we touched on in the 2011 summit was our molecular epidemiologic techniques that help us investigate outbreaks and investigate transmission. And there's been a great deal of research and development since 2011 in our laboratory, fueled in part by the Automated Molecular Detection Initiative here at CDC. And you'll be hearing examples of a web-based application known as GHOST, which is based on next-generation sequencing that's going to help us and help state and local health departments investigate outbreaks, investigate social networks of transmission, and help public health get closer to that leading edge of transmission so we can intervene as quickly as possible and prevent transmission to others. Now, all of these issues are important, I believe, for the United States. They're also important globally. And while these issues are substantial and formidable here in this country, they're even more profound around the world. And I do want to join with Jono in thanking FINE for helping us identify some of those issues. CDC and our programs around the world are involved in hepatitis to various degrees. We also work with the World Health Organization as a global collaborating center on viral hepatitis, one of only 3 in the world. And I really see this global section of our agenda really serving that mission of being a collaborating center together with WHO. And so while we're looking for new strategies and new technologies to help us here in this country, we're going to try to do the same globally, and that's what we're going to be talking about in that session. Now, there are a wide variety of strategies that help us improve access to testing and then successful action based on that information to improve the health of that individual and improve the public's health. And I realize that not all of those are on the agenda. Other strategies that come to mind include provider education, clinical decision tools that prompt testing, and reimbursement issues about what's getting paid, for, who's getting paid for testing in various settings. Those are all legitimate issues, and I encourage you to bring those up in the discussion while the agenda is focused on some key priorities that we wanted to make sure we had attention to help us drive our work, improve the quality of our work, and help us refine our priorities and programmatic activities going forward. So I want to thank again all of you for coming. I really encourage all of you to be very active in the discussion. I want to thank all the speakers beforehand for them them taking time to make the presentations. It's always a pleasure to work with people in hepatitis because we're a very committed bunch. We have really strong intervention tools, and working together, we can have a profound impact to improve the health of this country and the health of others around the world. So thank you again for your participation. I want to call on Michael and Daniel to come to the podium, and they can kick off our first session. They can begin calling on the speakers, and then the speakers, after their presentation, can join them at the table. Thank you again.
Well, thank you very much. I'm Michael Freed from the University of North Carolina, and I'm very pleased on behalf of my co-moderator, Dr. Daniel Johnson from the University of Chicago, to welcome everyone to the opening session, Diagnosis and Management of Current HCV Infection from HCV Testing to Cure. We have some excellent speakers. We're going to have some lively discussion. Each speaker will have 10 minutes for presentation, then we'll have 5 minutes of discussion, and then there'll also be a small, short roundtable discussion at the end of this session. So with that, Dan.
Great. Thanks, Mike. It's my pleasure to introduce Leslie Miller, who's the medical director at the Grady Liver Clinic and also associate professor of medicine in the Division of General Medicine and Geriatrics at the great University of Emory University here in Atlanta. Leslie?
Great. Thanks so much, and really appreciate the opportunity to be here and talk about my favorite subject, which is hepatitis C. So I'll be talking about testing for diagnosis of current HCV infection. So the objectives over the next 10 minutes are to understand the impact of screening and linkage to care programs using HCV diagnostics on elimination efforts, to learn about the implementation of HCV diagnostics as an integral part of our screening and linkage to care program at Grady Health System, and finally to identify challenges and opportunities for applied HCV diagnostic tests in a real-world setting. So some of this has just been said, but really to open up, why screen for HCV infection? And put quite simply, it's common, deadly, and curable. In terms of being common, we know that close to 4 million Americans are infected, but only 50%, as we heard, are aware of their infection. In terms of being deadly, hepatitis C now causes more deaths than HIV and 59 other infectious reportable conditions combined. But the silver lining to this is that it's very easily cured now. We have more than 95% SVR rates with our current direct-acting antiviral therapies. But really, to achieve the efficacy of these great new treatments, we really need to start with screening. We can't get folks into care and get them on these medications if we don't screen them. So we really need to attack this 50% of undetected cases. So I'd like to kind of take this locally, and we'll take a trip about 6 miles southwest of here, down the road to Grady Health System, which is where I practice. So this is Grady on a beautiful Atlanta day. So it's our public hospital in Atlanta. It's the largest hospital in the state of Georgia, and it's an academic setting, so the major training site for Emory and Morehouse schools of medicine. It's actually a statistic that 25% of all practicing physicians in Georgia have at one point rotated through Grady. Great place to learn. So why screen at Grady? One, we have the patient population. We have a majority of African American patients who are mostly and underinsured. We have a high prevalence of baby boomers and other high-risk groups for viral hepatitis, and a high prevalence of HCV infection. And I'll leave you at the edge of your seats we'll learn about what that prevalence is in a couple slides. The providers, so we're academic general internists and community-based family practitioners. And finally, we have internal medicine residents, both from Emory and Morehouse schools of medicine. And the idea is that if we can teach these trainees to screen during their training, they'll take this practice with them when they leave our training setting. Finally, we have the Grady Liver Clinic. So this is an innovative model for hepatitis C care in that it's primary care-based and generalist run. So I'm a general internist. I'm not a hepatologist, but learned how to do hepatitis C treatment back in 2004 and have trained sort of subsequent generations after that. So it's a model that really works, especially for our patients who are uninsured and don't have access to specialist care. We provide access to care for uninsured patients. We train providers in hepatitis C care. And finally, we serve as a linkage venue for screening programs. So I think one of the big challenges in implementing a screening program is, it's easy to screen, but what about getting patients linked to care? So we kind of started with the linkage piece and then added on screening after that. And I just want to show you this brief video clip to show you kind of the sense of the prevalence of hepatitis C in our population. So this is a patient who we treated and cured, and we were chatting about hepatitis C recently, and she said this, and I was like, I have to capture this on camera. I can't believe this.
All right, I don't know anyone in my age group, age 60 to maybe 67, who does not have hepatitis C. And I know a lot of people.
So just to reiterate, she does not know anybody who does not have hepatitis C, and this is what we're seeing in our population at Grady. So to implement screening at Grady, we've had 2 funded projects. The first was a CDC-funded project that ran from 2012 to 2015, and we based the screening in the primary care center at Grady, so hospital-based primary care. We taught the residents to implement birth cohort screening, and the goal is to identify previously undiagnosed cases of hepatitis C and then link those positive patients to care, either at our primary care-based liver clinic or the Morehouse Infectious Disease Clinic, which is also hospital-based. Once that funding ended, we got follow-on funding from Gilead's FOCUS program, and that program is almost at the end of its first year. So in addition to the primary care center, we added 5 of the 6 neighborhood health centers. So Grady has a network of health centers around Atlanta. And so now all of those centers are screening. We also added the geriatrics clinic. We find the average age of our hepatitis C patients at Grady is upwards of 60. So we found that a geriatrics clinic is actually an appropriate place to screen. We have resident and faculty screeners now, and we've implemented an EMR prompt, which I'll show you in a second. So in order to implement this screening program, we're following the CDC recommended testing sequence for identifying current hepatitis C virus infection. So we start with testing for HCV antibody. And this was the prompt we created. We use EPIC as our EMR, and this is a really smart algorithm. It's a best practice alert, and basically we designed it so that it fires for patients who were born between 1945 and 1965 and who don't have a previous diagnosis or test in the system for hepatitis C. And this makes it really easy for the providers. If this pops up, it means your patient really needs the test, and all the provider needs to do is click on the accept button in the bottom right corner, and that will automatically populate the HCV antibody order into their order set. So how does this sort of fit into the flow of our care at the primary care center and the neighborhood health centers at Grady? So ordering the antibody test once prompted is the easiest part. What we wanted to do in implementing this is we wanted to make it sustainable once our funding was over, and we also wanted to make it really integrated into usual care. So we didn't use point-of-care testing. We didn't have specific funding for the test. We just integrated it. So the patients, the normal flow is that their provider sees them, order a panel of lab tests, whatever they need that day, and the hepatitis C antibody is included in whatever other labs they're getting. The patient may or may not go to the lab that day. We have an outpatient lab on site on the same floor as the primary care center, but they could go that day immediately after clinic. They could go down the line. So there could be some time lag in between the time the provider orders the test and the patient actually gets it done. So once the antibody test results, if they're negative, they're done. But if the antibody's positive, or we often get low positive or indeterminate results, then the provider has to order the HCV RNA. And again, this relies on the provider actually seeing the antibody test result, putting the order into the computer, and then informing the patient and having them come to the lab. So again, points of introduction of lag time here. And this can take, honestly, for some of our patients, anywhere from a week to 2 years to get the RNA test done. So this is a real gap in the care, is getting the second RNA test. And we'll talk about our attempts to implement reflex RNA testing. We're not there yet, but we're working on it. Once the RNA test is complete, if they're RNA positive, we link them to care, and if they're RNA negative, no further testing is needed. So just to show you our outcomes using this process, and this is close to 4 years of data with the combined screening programs, we've tested close to 12,000 primary care patients at Grady over the last 3.5 years. We have a 7% prevalence of antibody positivity that was much higher than we expected, and this is a predominantly baby boomer population. So out of the 7% who are antibody positive, 76% actually received their RNA test. And I want to point out that this required both intensive navigation navigation and a lot of time. So we followed some of these patients for close to 4 years now, and sometimes it honestly took that long to get the test done. Out of our RNA tested population, 67% were viremic. So this was actually a bit lower than I think is usually quoted and than what we expected. Once we have the RNA test done, the linkage, as I mentioned, is actually probably the easier part for us. We have this primary care-based clinic for them to land. So for us, the challenges are on sort of the middle part of the cascade, getting them RNA tested. And then we have to think about, with that relatively low prevalence of viremia, is there some way we can identify folks who sort of have a lower pretest probability that they'll actually be viremic? So in terms of closing these gaps, one-step testing would really do it. So in terms of the antibody testing, it's readily accepted by patients, it's easily integrated into usual clinic care, and it's inexpensive. But then we get to the RNA testing. So it requires, in our current model, and I think in many institutions, an additional lab visit. And for our patients who have a lot of socioeconomic challenges, financial, transportation, returning for an additional lab visit can be really cost prohibitive. And I was talking to our navigator the other day, and she mentioned that, in a conversation with a patient, encouraging the patient to come in for the RNA test, the patient was like, well, I need to pay my light bill this month, so can I come next month to do it? I mean, they're really competing priorities here. It requires intensive navigation to achieve even that 76% RNA testing level, and it can create redundancies in our linkage strategy. So often we'll actually link just based on the positive antibody, because the patient will need to come back, theoretically a second time for an RNA test and a third time for a visit if they're positive. So often it's more convenient for the patient just to link them, have an introductory visit, have their RNA test done at that linkage visit. Also, this half a diagnosis breeds unnecessary patient anxiety. And you can imagine for the patients who wait months or even a year to get their RNA test being stressed that they're infected and not even knowing. So I actually saw a patient in clinic this week who had his antibody test done in June and just came this week for his RNA test, and he was undetectable. But he had to live for those 3 months not knowing his status. So what are some of the barriers that we've experienced in implementing reflex RNA testing? So actually our medical executive committee at Grady has approved reflex RNA testing as a strategy as of January of this year, and we're just still really facing challenges getting this implemented in the lab. So general challenges, we need the institutional buy-in, which we've gotten at our institution. The challenge of the molecular assays not largely approved for diagnosis is a challenge on the lab side. It requires multiple system changes, so phlebotomy staff retraining. We would need to change our EMR EPIC order set to include the reflex RNA test. And then we need a method for avoiding duplicate RNA tests. So, we're early in the academic year. We have a lot of trainees, and our interns are very zealous about ordering tests. You can imagine there might be an antibody test ordered multiple times, even if there was a previous positive, and we don't want that always resulting in an unnecessary RNA test every time. Challenges with specific strategies. So we first explored a one-tube method, so reflexing off the original sample collected for the antibody test. And we use an Architect instrument at Grady. We have an in-house lab. And there's a lot of concern for carryover with the amplification with the PCR test. And so that strategy was considered too prone to contamination. And so now we're looking at a two-tube method. And this is all actively in the works. We haven't gotten there yet. When you think about collecting 2 tubes on that 93% of people who are not going to end up being antibody positive, that's a lot of extra phlebotomy and a lot of extra cost. And then just in terms of the logistics of routing the specimens in the lab, if we collect 2, there needs to be a system and retraining of personnel to actually hold those tubes over while the antibody tests are being run. So those are just some of the practical issues we're facing. So what are opportunities here? I think making reflex RNA testing standard of care would solve a lot of these problems, and we can do that by creating and disseminating best practices for implementation. So I know from our experience, we're sort of struggling with this in our silo, and sort of having best practices that institutions can share among themselves would be extremely helpful. There's a great model that the Cleveland VA used where they had 100% success in doing RNA testing on all their antibody positive samples by using a continuous quality improvement process plus electronic HCV population management. And then I think we'll hear more about this later, but alternate strategies for confirmatory testing, including point-of-care RNA testing or HCV core antigen testing, are possible solutions as well. And just to sort of end on a positive note here, so when these diagnostics are implemented, and they have been in our system, it really helps lead toward cure. So out of all of the screening and the RNA testing we are doing, we're getting folks into care, we're treating them, we're curing them, and our cure rates and treatment initiation rates are skyrocketing. So, this really does make a difference and gets us one step closer to elimination. So I'd like to thank you for your attention and happy to answer questions if we have time.
Testing for hepatitis C got a great B recommendation, and therefore emergency departments are not considered a primary care setting, and therefore don't get reimbursed for their testing. So I wonder if you could elaborate on that in terms of if the Gilead funding stops, and what would you do at that point?
Sure, thanks for the question. So this is all done so far just in primary care. We're actually proposing, and we have a renewal for this year to expand into the emergency department. But for now, primary care-based screening, we think will be sustainable, and that's why we really wanted to make this a process that once the funding ends, we can continue. So they're actually not paying for the tests, either the antibody test or the RNA test. What they're really supporting is provider education and mainly a patient navigator and a data manager to sort of follow patients along this cascade data-wise. But the goal is that as we show the impact, so the prevalence of the positive patients, the number of patients we can get into treatment and get cured, that this will kind of become adopted by the institution, by Grady itself, because it's an absolutely important public health practice that we're doing. So the idea is that once the funding ends, this will just be adopted by the institution and will remain part of usual care.
Hi, I'm Catherine Soring with Siemens Healthcare. I'm just curious, you said you implemented the boomer screening, but what about the recent publications showing that a lot of infections are occurring in the young and primarily drug abusing? Are you looking, given the population Grady serves, are you looking to potentially expand testing?
Yeah. So that's a great question, and that's why we are expanding. So our renewal of this program will expand not only into the emergency department, but also the inpatient setting. Again, focus on baby boomers, but we will be testing using risk-based strategy as well. In our population at Grady, interestingly, we're not seeing a lot of sort of young injection drug users and new infections. So our average age is in the 60s, and folks who were infected from injection drug use or other things way back when, and have been chronically infected for 30 or 40 years or so. We're very interested in this, prevalence outside of the birth cohort. And the challenge that we're facing with that is that, we can get the test paid for baby boomers because it's part of the USPSTF recommendations. However, screening outside of the birth cohort is not a recommendation at this time, and so we've had trouble sort of justifying the cost. So that would be something that, a grant would need to fund those tests.
Dr. Miller,
yes.
One of the problems that many people have with using the EMR to try and get people to change behavior is that people fatigue to its presence. Mm-hmm. I'm wondering how you've set up your system to try and anticipate that problem, mm-hmm. And what's been the feedback from people who are using it?
Yeah. So, we see the EMR prompt as almost an adjunct. We really started this, so we didn't have the prompt when we had our CDC funding project, and basically what we did was a lot of intensive resident provider education. And so we sat down with every single resident one-on-one, gave some pearls on the recommendations for screening. And because we have such an active HCV treatment program at Grady, I mean, they're hearing us give lectures and webinars and talk about this all the time. And so I think we've sort of created this culture of hepatitis C is important, we need to screen for it. And so the prompt is kind of an add-on to that, but I honestly think probably the biggest issue and what sort of supports when there is that alert fatigue is that folks are just thinking about it, and it's kind of after 4 years now become ingrained.
Well, thank you very much.
Thank you.
And our next speaker is Dr. Adrian DiBiscelli, who is Chairman and Professor of Medicine at St. Louis University in St. Louis, and he'll be speaking to us today on testing for management and monitoring during antiviral therapy.
Thanks very much, Mike. Thank you to the organizing committee for inviting me to this, what promises to be a very interesting meeting. My task, I think, is fairly simple. It's to talk about testing for management and monitoring of antiviral therapy. I'm a hepatologist, have been treating patients with hepatitis C for 20 plus years now. My disclosures are listed here. Here's what I'm not going to discuss, because other speakers are going to discuss these things, but this is part of what should be considered. We've heard about testing of current HCV infection. We're going to hear about treatment, testing after treatment fails, high-risk and special populations, and then the question of national surveillance. In my mind, the goals of testing are to ensure that the patient is actually viremic before you start treatment. The viral load may determine the duration of therapy, depending on the regimen used. One needs to be able to assess the safety of treatment while on therapy. I have in parentheses here to assess the on-treatment response and compliance, because frankly, this is sort of a soft goal. And then to determine sustained virologic response or viral cure. And for this presentation, I've relied very heavily on guidelines, in this case from the ASLD IDSA guidelines. And I'll read these. They're fairly obvious. One starts out with staging of hepatic fibrosis and baseline testing. Staging of hepatic fibrosis is essential prior to HCV treatment. Sometimes advanced fibrosis may affect the outcome of therapy, but also one needs to know in order to assess whether the patient is at risk of hepatocellular carcinoma or hepatic decompensation. One needs to consider the potential drug-drug interactions with concomitant medications, and that's recommended prior to starting antiviral therapy. And then the following laboratory tests are recommended within 12 weeks prior to starting antiviral therapy. So a blood count, an INR, hepatic panel, a calculated GFR for renal function, and a thyroid test, but only if interferon is part of the regimen, and that's vanishingly small these days. The viral load and genotype. The following laboratory testing is recommended at any time prior to starting antiviral therapy: HCV genotype and subtype, and then quantitative HCV RNA or HCV viral load. And I guess we'll hear later about whether a core antigen may substitute for that. Notice that this guideline says is recommended at any time prior to therapy, but there are several third-party payers who require testing proximate to treatment, typically within 6 months. So if it's a year or two old, that's not good enough for them. One does need to be aware of the risk of hepatic decompensation while on therapy. So the guideline says that patients scheduled to receive an HCV NS3 protease inhibitor, they're listed here, paritaprevir, Simipravir, Grazoprevir, should be assessed for a history of decompensated liver disease and their Child-Pugh score calculated. Patients with a current or prior history of decompensation, ascites, hepatic encephalopathy, jaundice, or with a current CTP score of more than 7 should not receive a therapeutic regimen that contains one of these drugs. For patients with intermediate severity with a Child-Pugh score of 5 or 6, who cannot be closely monitored for laboratory or clinical symptoms, they should simply not receive, they should receive an alternative treatment regimen. Resistance testing. So this is what the guideline says about this. Based on known inferior response in patients with the presence of baseline NS5A resistance-associated variants or RAVs, NS5A resistance testing is recommended in patients with HCV genotype 1A who are being considered for therapy with this one specific regimen, elbasvir/grazoprevir. If baseline RAVs are present, that is polymorphisms at amino acids 28 and so on, one extends treatment to 16 weeks. It's not that treatment is contraindicated with this drug. One simply needs to extend the treatment and use weight-based ribavirin to decrease the rate of relapse. These are the NS5A resistance-associated variants with potential for clinical significance, and the positions as listed here, the wild-type amino acid here, and then the variants that may be seen. So it's only if one is considering this particular regimen in a patient with HCV genotype 1A do you do this testing to determine the duration of treatment. So now you've started treatment. How do you monitor during treatment? Guidelines says clinic visits or telephone contact are recommended as clinically indicated during treatment to ensure medication adherence and to monitor for adverse events and drug-drug interactions. Complete blood count, creatinine level, GFR, hepatic function are recommended after 4 weeks of treatment and as clinically indicated. TSH only for those patients receiving interferon. And then more frequent assessment for drug-related toxic effects. So a blood count for patients receiving ribavirin is recommended as clinically indicated. Patients receiving elbasvir/grazoprevir should be monitored with a hepatic function panel at 8 weeks and again at 12 weeks if their treatment is extended. A 10-fold increase in ALT activity at week 4 should prompt discontinuation of therapy. This does occur, but it is really quite a rare phenomenon. But that's essentially what you're monitoring for worsening of hepatitis. And the patients who are at risk of this are those who start out with cirrhosis, borderline hepatic decompensation. That's why you need to assess the severity of liver disease to begin with. Recommendations for discontinuation of treatment because of lack of efficacy. If HCV RNA is detectable at week 4 of treatment, repeat quantitative HCV RNA load testing is recommended after 2 additional weeks, that is at week 6. If the viral load is increased by more than 10-fold or 1 log on repeat testing, then you say you failed, discontinuation of treatment is recommended. Frankly, this just doesn't occur if the patient's taking their medicine. I happen to look over a list of my patients who are undergoing treatment at the moment, about 20 or 25 of them, in a spreadsheet looking at the week 4 result. There are a few who have a trace of virus and it never goes up. It just doesn't occur. But in any case, this is what you do if it does occur. The significance of a positive HCV RNA test result at week 4 that remains positive but lower than where it was is unknown. No recommendation to stop therapy or extend therapy can be provided at this time. So as long as the virus is coming down, even if it's not undetectable, the patient is likely to, almost certain to respond, keep going with therapy. So assessing viral response then. Quantitative HCV viral loading testing is recommended after 4 weeks of therapy and at 12 weeks following completion of therapy. Antiviral drug therapy should not be interrupted or discontinued if the HCV RNA levels are not performed or available during treatment. Now notice here there's a week 4 on therapy and then 12 weeks after stopping. There's nothing in between that's recommended. People do things in between and after, but it's not recommended necessarily. Quantitative HCV viral load testing can be considered at the end of treatment and 24 weeks or longer following the completion of therapy. What's not recommended is monitoring for HCV drug resistance-associated variants during or after therapy. Simply unnecessary. So that's the AASLD IDSA guidelines. Up to Date also has some recommendations that are variants of this, and I think they're worth looking at. And of course, other organizations have recommendations too. Patients diagnosed with chronic HCV should also be tested for HIV, hepatitis B, and hepatitis A, and vaccine should be administered to those without immunity to the last 2. Additionally, it's reasonable to evaluate for and exclude other causes of chronic liver disease, such as iron overload syndromes, autoimmune hepatitis, and so on in patients with raised liver enzymes. This is I sent another version of the slide that was a little easier to read. I apologize for this. I'll walk you through it. Monitoring viral levels during treatment with interferon-free regimens has minimal prognostic value. The main reasons to check viral levels during therapy are to assess adherence to the regimen and to document the treatment course and virologic response in case patients relapse and warrant retreatment. Given the expense of medicines and the potential risk of viral resistance with inappropriate use, we check HCV RNA quantitative testing at week 4 in clinical practice. The clinical value of a week 12 or end of treatment viral level is uncertain, and most providers do not routinely check it. It is undetectable in the vast majority of treatment patients. SVR should be assessed by checking viral load 12 weeks after stopping treatment. So there are a few regimen-specific recommendations in up-to-date with this combination, elbasvir, grazoprevir, checking liver enzymes and bilirubin levels at week 8 and week 12 because of this possible risk of exacerbation of liver disease. This is the AbbVie regimen, paritaprevir, ritonavir, ombidisvir-based regimens. Similarly, close monitoring for hepatic decompensation is warranted during therapy. Ribavirin-containing regimens, we check for ribavirin-associated anemia during therapy. And of course, for women of childbearing age, taking ribavirin, assessment for contraception use and pregnancy testing should be performed. Men taking a ribavirin-containing regimen should be counseled on contraceptive use. So this is my last slide. I've shown slides with a lot of words on it, but this, for treating clinicians these days, the first course of treatment is really very simple, and this slide is hence very simple. Before treatment, this is what you need. You need a quantitative HCV RNA. You need a genotype. You need some assessment of liver disease severity. You need a week 4 quantitative HCV RNA to know that the patient is compliant with therapy and headed in the right direction. And then you assess SVR 12 weeks after stopping treatment. This is what I do in my practice. I'll see the patient before treatment. They get started on treatment. I say, come back at week 4. And then I say, goodbye. Come back and see me 3 months after stopping treatment. I don't see them in between unless they're at risk of, I'm using an at-risk regimen, or they have advanced liver disease when they need to be monitored for safety with protease inhibitors, if they're using protease inhibitors, ribavirin, or interferon, which is very rare these days. So I'm going to stop there and take any questions that there might be. Thank you.
Okay, we can open it up for any questions. Adrian, I'd like to just talk a little bit more about this week 4, because we're talking about expanding this to a lot of different kinds of healthcare providers who are treating hepatitis C. And you say that you use this as sort of a marker for adherence, and that it's rare that we really take an action based on the week 4 because, we just see patients taking it. And I'm wondering whether adherence really should be checked or should be assessed carefully actually prior to starting therapy with education of the patient and making sure they understand the importance and selecting that patient who is most likely to adhere to treatment.
Well, I think the way you assess that is by what Dr. Miller said. If they actually come back for that HCV RNA test, or they see you in the office and come back to follow up, if they don't come back, nothing's going to work. That by itself is a test. You get into other things, like in the state of Missouri, which is unfortunate in its Medicaid program, in requiring 3 months of abstinence from illegal drugs and alcohol with mandated urine testing for 3 months. So those patients have to come back for 3 months. That's another measure of adherence there. I'll say my other reason, Mike, for liking the week 4 RNA testing is when we write a prescription, there's often a gap of several weeks up to even a couple of months until the patient actually receives their medication. And I sort of worry that I've lost them. And this week, coming back for the week 4 result is a way for me to try to get control again of understanding what the patient is doing, are they receiving their medicine, and of course, are they compliant. So in my mind, it serves multiple purposes. Can you do without it? Probably, but otherwise you're saying treat before treatment and assess SVR at the end of treatment, and that's like a long period.
Yeah. No, I definitely check week 4 RNA. I'm just making it making it provocative about whether we actually need it or there are other ways. Would a phone call to the patient be sufficient, for example, to assess adherence?
A lot of my patients don't have telephones that work. I do have to say. This is a very serious issue in the patient populations we're treating these days. The week 12 HCV RNA and the end of treatment, in my view, that's a waste of time. But it's being done by a lot of providers. I don't think that's necessary, clearly.
Ray?
Just a quick question. What happens after the week 12? Do you ever check one more time at 24 weeks or thereafter?
Yeah, I'm superstitious. So almost all of my colleagues, when I'm in a group with a group of hepatologists, we say, do you need to check after week 12? And they say, no, but we do it anyway. And it's just, I think, a measure of how long we've been doing this. We're sort of, we've been disappointed with relapses from interferon before, but in reality, it's really not necessary. But I still end up doing it. I say one more time, and then we're done.
How about your patients? Do you try to talk them into not coming back?
Every week in my clinic, I say goodbye and I hug 2 or 3 patients that I've cured. I've been following them for 10 or 15 years. The cirrhotics, of course, stay with me to be screened for hepatocellular carcinoma. Those with lesser degrees of fibrosis, I'm saying goodbye to them on a routine basis.
Hi, Gilberto Baum, Division of Viral Hepatitis. Very quick question here.
Oh, there you are. Sorry.
Yeah. So during your presentation, you mentioned that detecting or identifying variants that are resistant variants, right? It might be useful to determine the length of treatment. So I was just wondering why in your final conclusions you don't mention anything about testing for the resistant variants.
After treatment?
No, before treatment.
So it's just for that one particular regimen where the therapy doesn't seem, by itself doesn't seem to be able to effectively deal with the resistant variants. I think we're going to have another presentation on testing after failed treatment, after relapse and so on, which is when I think you really need to be doing more resistance testing than otherwise. But otherwise it's this very narrow issue of this one particular regimen where you need to test, because if the RAVs are present, you extend treatment and you add ribavirin. I think John had his hand raised.
Yeah. It was a great presentation, Adrian. Thank you. I just had a question about staging of liver disease. What type of test do you think is reliable for you? Do you use scans? Do you use FIB4, APRI, et cetera?
I didn't talk about this. Thanks for bringing this up, John. I focused in terms of liver disease severity on the end stage, so assessing the degree of decompensation in a patient with cirrhotic, but you're asking the question of what about lesser degrees of fibrosis. And we really, in these days, rarely do liver biopsies anymore, which used to be the standard of care. We rely on non-invasive testing, either FibroScan or blood testing with FibroSure-like tests, which are not quite as accurate. Here's what I do in clinical practice. I do a FibroSure and a FibroScan, and then when I'm trying to persuade the insurance company to pay for the drug, I use whichever test shows the most severe fibrosis. Sorry, that's just what I do.
Thank you very much. If you could take a seat at the table, and then Dr. Miller, could you do the same? It's my pleasure to introduce our next speaker, Brian Edlin. He's the Chief Medical Officer for the National Center of HIV/AIDS, Viral Hepatitis, STDs, and TB Prevention here at the CDC. Dr. Edlin?
Thanks, Dan. It's great to be here. It's great to be back at CDC. I've been away for about 20 years and back for a couple of months. This is a great meeting. I really appreciate the opportunity to speak. I've been asked to talk about distinguishing relapse from reinfection. This is an important issue both clinically and for epidemiologic purposes. Relapse really represents a regimen that failed. So we have to consider questions about adherence. Was there a lapse in therapy for one reason or another? Does the patient now have drug resistance, or did they have it to start with? Were there subpopulations that the therapy wasn't effective against? And then how do we approach choosing a salvage regimen from regimens that may be available now or in the future? If the patient is reinfected, it's really a whole other set of issues. The patient was re-exposed. There is a iatrogenic exposure, sexual exposure, but most often it will be through injection drug use. So what do we do about reinfection? How do we respond to it? And really prevention of reinfection starts before we start treatment, before we make a decision about starting treatment, with a clinical history, questioning the patient in a non-judgmental way. What has been their experience with using drugs, if any? Are they using currently? Have they used recently? If so, what are their thoughts about their use? Are they interested in cutting down or stopping? Have they thought about cutting down or stopping? If not, are they? If they're not currently using, are they at risk for relapse? Have they tried to stop in the past? What's worked? What hasn't worked? What are the things that might trigger a relapse? What are the things they could do to stop that from happening? And sort of neutrally approach drug use, because we know that although we know a lot about the drawbacks of drug use, there are also benefits. And we really have to engage with the patient in a neutral, objective way about what their feelings are about both of those. What does the patient know about safe injection? What are their current practices? What access do they have to the means to inject safely? And then based on all of these things, is this the right time to start treatment? Do we want to work for a while on prevention and on building the relationship with the patient first? These are all sort of individualized questions. If the patient is either using, has recently used, or is at risk for relapse, then we want to make sure they have access to the means to keep from getting infected or transmitting, or reinfected or transmitting infection. We know a lot about sterile technique. We're very familiar with that, accustomed to it. Patients are not, so we need to talk with them about how, if they do inject, how to inject without contaminating their drug or drug solution or equipment. Their syringe, do they have access to sterile syringes? Their syringe services programs, also called needle and syringe programs. These are needle exchange programs, but they're not available everywhere. Pharmacies are actually more available than syringe services programs. They're on almost every corner in many cities and almost every neighborhood outside of urban areas. It's legal to buy syringes in many states, and when it's not legal to buy them without a prescription, we can prescribe them for patients so they have the means to avoid infection. Medication-assisted therapy is one of the most effective therapies that we have in medicine. It prevents people from being in withdrawal. It prevents a situation where there's an urgent need and where if a used syringe is the only one available, it will almost certainly be used. So this is methadone or buprenorphine. And detox is not really a treatment. These drugs are used sometimes for detox, but that basically takes the patient off the medicine. They don't benefit from it. Many syringe programs have peer outreach programs. These programs are very effective, and often it's the people who enroll in them become the peer educators who benefit most. This is another important way to help people stay safe. Staying safe itself is actually an evidence-based program building on strategies that drug users have used who have stayed uninfected. And focusing on ways of preparing for situations where infection might occur and developing strategies for those situations. And finally, if a patient has a partner that they inject with or might inject with, a group of people with whom they might, to whom they might be exposed, we can treat the group as a whole, or we can treat both partners rather than treating one and then putting them at risk for being exposed to the other. So we now have a patient that's become undetectable, and if we tested for that, and now 12 weeks post-treatment is positive. How do we distinguish? And of course, we have genotype from before treatment and then from after treatment. We can do sequencing, but this is really a sort of a research tool, not really clinically available very much, and does require having saved a specimen from before treatment, and if possible, if there is an exposure, having a sample from the putative source person. Consensus sequencing is the most common and simple method, but doesn't really detect minority variants unless they're fairly substantial prevalence. Endpoint dilution can detect more, and next-generation sequencing that we'll hear more about later at the meeting can detect thousands of sequences from the same sample. So it's very effective for detecting minority variants, but it's difficult to get and expensive. And then the clinical history is important to talk to patients, to understand if they've been exposed or might have been exposed, and to look at the timing of recurrence of viremia, although based on the previous talk, that may be a moot point if we don't know when the viremia occurred. So typically, if a patient is going to relapse and we have pre- and post-treatment samples, we'd expect them to be the same. If the patient is reinfected, we'd expect them to have different sequences, and based on that, those studies, we could draw those conclusions in a sort of simple scenario. But is that always the case? Can a patient relapse with a different sequence from the pre-treatment sequence? And the best example of this is in a situation where there is a mixed infection with two different genotypes, and particularly now with type-specific therapy. The patient in this case has a genotype 1 infection, but with a minor genotype 3 variant that's undetected on the initial genotyping. Patients treated with sofosbuvir and ledipasvir, the genotype 1 virus is eliminated. The sofosbuvir suppresses genotype 3 during treatment, but single drug therapy isn't effective at eradicating it. It reappears afterwards, and now we have a patient who's relapsed, but with a new variant and this a new genotype in this case, but can also occur with a new variant with a different sequence. So this isn't always as easy as it seems, but with next-generation sequencing, if we have that technique available, we should be able to find the post-treatment sequence in the pre-treatment sample. If it's not there, we can be fairly certain that it's a reinfection, and of course that can be confirmed if we have a sequence from this patient to whom the person to whom our patient was exposed. What about getting reinfected with the same strain? Is that possible? Well, certainly if a patient is re-exposed to the same partner or the same person from whom their initial infection came, they might well have the same sequence, and this could be difficult to discern. So in summary, I'm out of time. In summary, I think I've covered the main points. Basically, if a patient, I'm trying to highlight the differ in the lower right-hand corner. If the sequences are different, it's certainly suggestive of reinfection. Next-generation sequencing can help. And then the clinical history of the patient, if the viremia appears within 4 weeks after treatment, it's more likely to be relapse. But as has been pointed out, this may be a historical issue if if those samples aren't really drawn. Conversely, if the post-treatment and pre-treatment samples are identical, that certainly suggests relapse, but may not necessarily be the case. So I'll stop there.
Great. So this presentation's open for questions.
have to say I'm an epidemiologist. I'm not a virologist, so I'll try to answer questions to the extent I can, but I have colleagues here who may be able to help.
Cami Graham, Beth Israel Deaconess. So fortunately, I've only had a couple of people get reinfected after being cured. They weren't the injection drug users. They were men who have sex with other men. So do you have any suggestions on how we counsel people to try to decrease the risk of reinfection in that group?
I don't have as much experience with that group, but I think the principles probably are similar. There may be others who could answer that question better. One wants to talk with the patient about potential risk behaviors, make sure they understand them, try to ask them in an open and objective way what they think the risk might be and what strategies they might be able to take to avoid getting reinfected. It may be a complicated issue in HIV-infected men who have sex with men because HIV is also an issue. Superinfection may also be an issue with resistant HIV strains and so on. So there are complicated issues. It might be important to make sure patients understand. Is that what you're hoping to hear? Or the fact is there are some studies of injection drug users and of men who have sex with men post-treatment. The reinfection rates in the injection drug users who've been treated to date have been actually quite low, and they've been considerably higher in the studies of gay men.
I was just going to add, I think it's very important to counsel patients that they can be reinfected. That they need to be aware of that. So in terms of how you prevent it, that's Cammie's question, but I think the first step is to let them know that they can be reinfected. It's not like some viral infections, of course, where you're now immune.
Go ahead. Hi, Brian. Bernie Branson. My experience in substance use programs is that it's almost impossible, though, to get RNA tests on substance users. I mean, getting them screened with antibody tests with a point-of-care test is relatively easy, but a lot of the programs are not very well equipped. I'm wondering, in terms of this whole issue, what are people recommending with respect to rescreening for RNA in people who are going to be persistently antibody positive?
I'm sorry, what's the difficulty with getting RNA tests? Are you talking about...
in substance abuse treatment programs in general, they're not very well equipped to set up for phlebotomy or to transfer specimens, and you're dealing with a very high-risk population. And so, you know, they're going to be antibody positive, which is relatively easy to screen for, but once they've been treated, what do you recommend for rescreening for RNA?
A lot of programs that treat people for substance use don't really have a very advanced approach to hepatitis C in the first place. And so I think that's really best managed by trying to develop partnerships. People who treat hepatitis and people who care for people who use drugs historically seldom ever cross paths. And so this is, I think it's really important in an individual program level for people to meet, to talk, to collaborate, to know each other's names, to refer patients back and forth. And I think that's important, not just for getting the follow-up RNA tests, which are necessary periodically in people who have ongoing exposures or ongoing risk, but also for getting the initial tests for understanding hepatitis C in the first place, and for getting people access to treatment, which many people in substance use treatment programs currently don't have. So that's really, I think, an important bridge to be built.
All right, thank you very much. Our next speaker is Dr. Ray Kim, who is a professor and chief of gastroenterology and hepatology at Stanford University Medical Center.
Thank you. I'd like to echo the other speakers by thanking John and the organizers to inviting me to this interesting conference. I only have 10 minutes, so I'll be brief on the gratitude part. Forgive me. So my task is to talk about testing of high-risk and special populations. I am a hepatologist, and I do epidemiology research, so my bias will come through my talk, I think. To me, as a hepatologist, liver fibrosis, as Adrian pointed out, is a very important component of hepatitis C's disease burden. So we recently put together a paper based on NHANES data serially, looking at the prevalence of advanced fibrosis and cirrhosis based on FIB-4 score and APRI score. And the point of the paper was that as we compare the prevalence of these conditions across the different eras, there was an increasing prevalence of serious fibrosis over time. As of the most recent era, 1 out of 6 patients had serious levels of fibrosis, indicating the importance of hepatitis as a disease burden. But the other part of the paper that I want to talk about is when we looked at the proportion of people with advanced fibrosis between patients who were aware, subjects were aware of the infection compared to those who are unaware at the time of the survey. The percentage was exactly the same, if not higher, in people who did not know about their infection, indicating the importance of screening in asymptomatic individuals. So when you talk about screening in populations, my task, I thought about 3 overlapping circles in terms of high risk and special populations. One first circle is high prevalence situation. People who inject drug, I apologize for the typo, PWID, I was jet lagged and dyslexic, or people who are incarcerated, maybe the first group. The second group may be people who are at high risk of poor outcome. And as a hepatologist, the abnormal ALT is an important feature in people with alcoholic liver disease or concomitant fatty liver disease, or diabetes would be such examples. And the third group may be people who have unusual diagnostic characteristics, and examples may be immune disorders of a congenital kind or others. Then there are overlapping circles. HIV may be an example where there's a high prevalence, high disease impact, and also in certain populations, certain situations, diagnostic characteristics are unusual. And the other may be people on dialysis where prevalence is high, disease impact is high, and also we'll talk about the diagnostic characteristics there. So those are the few patient populations that I'll discuss. But given the limitation of time, I won't be able to talk about every single category. It's been mentioned already several times that the incidence of acute hepatitis C is increasing in this country again, and that is mostly due to rise in the incidence in the younger population, people in the 20s and 30s, and this is mostly non-Hispanic whites. And as the next slide will show, this is suburban and non-suburban and urban areas. This is the most recent MMWR talking about this point, describing the incidence of acute hepatitis C among people under age of 30 in these 4 Appalachian states. And as you see here, more recent recent years, there's a significant rise in the incidence of hepatitis C. And surprisingly, there are higher incidence in the non-urban areas compared to urban areas. And 75% of those who were reported have injection drug use. And these were mostly prescription, but also heroin use was prevalent. So these are the populations where hepatitis C is most common. And I think the subtext of this talk was the question whether the prevalence is so high that, or prevalence is high and pre-test probability is so high that you don't need to go through antibody testing. I don't think we're there yet with this prevalence, but we can talk about it during the question and answer session. The second population where the prevalence is real high is obviously the incarcerated population. This is the most recent paper that I could find that looked at the prison inmate population. This is a study where the authors contacted state corrections department, all 50 of them, and found that there were 12 states that had consistent systemic reporting process. And those are the states. An astoundingly high prevalence of HCV was reported, the highest being New Mexico, Oregon, Iowa, and Maryland were the highest prevalence groups. And the paper also described the longitudinal trend in hepatitis C prevalence. The good news is that there seems to be a downward trend over time, but even the lowered incidence prevalence is still very high, and some are really high, as I showed you in the last slide, 40-some%. Is this high enough to go to directly NAT? Part of me says this is a capture population. They're not going to come back for NAT testing if they're antibody positive. So this may be a special case where direct NAT test may not be cost effective. The third population that I'll talk about is dialysis patients. And this is somewhat of an old data, but this is the largest data that I could find. And this slide shows that as the dialysis time goes longer, the prevalence of hepatitis C goes up, regardless of antibody or RNA testing, indicating that there is some sort of a nosocomial transmission going on over time in the dialysis unit, but no one really knows exactly what that process is. The second point that I'll make is that consistently about 20% of patients who are viremic and on dialysis, they are antibody negative. So this isn't one situation where directly going to NAT would make sense. So this is a KDIGO practice guideline. This is a guideline that's used by nephrologists as opposed to GI or ID. And in that guideline, they talk about hemodialysis patients, CKD stage 5. When they first enter hemodialysis, they are recommended to have hepatitis C testing. And I think this part is strange because by definition, this is a high prevalence setting, and you need to go directly to RNA testing. If you're negative, unless there is an outbreak, you go back and retest in 6 to 12 months. And if you're positive, then you need to go to treatment. And obviously, this is an outdated slide that you go to antiviral treatment given the innovation that allows treatment in hemodialysis population currently. If you do have a low prevalence setting, they recommend going to antibody testing and follow the usual algorithm. But I think that the right side of the slide is more relevant. In the remainder of the time, I'm going to talk a little bit about ALT. As a hepatologist, ALT is very important. This is a project that we're currently conducting, looking at the NHANES population 07 to 12. And we looked at 3 different ALT levels. So in women, less than 19 is a really, really ideally normal ALT. Over 30 is traditional abnormal cutoff, and 19 to 30 is somewhere in between, mildly abnormal, if you will. Same thing for men, the numbers are higher. And obviously, as the ALT level goes up in the NHANES population, the prevalence of hepatitis C went up. And it was 5% in the abnormal ALT group in women, and it was 10% in abnormal ALT group in men. So this is pretty high, and what you notice is that the gap between the antibody results and RNA result gets narrower as the ALT level goes up, indicating that the pretest probability for viremia is higher in higher ALT population. So then we asked ourselves, what about the birth cohort versus not? So when we divided the population into birth cohort, which is the darker red, versus the pink, birth cohort individuals were much higher in terms of hepatitis C viremia prevalence. But in people who are outside the birth cohort, if you had abnormal ALT, in women, there is a 3% HCV RNA prevalence, which I think is significant. That needs to be paid attention to. In men, same phenomenon, that birth cohort has a much higher prevalence, again, validating the current recommendation to use the birth cohort for screening. But in people who are outside the birth cohort, abnormal ALT was associated with 3% prevalence of hepatitis C. So abnormal ALT is important to hepatologists because the most common cause of abnormal ALT is fatty liver disease in these days. And this is a patient of mine, a 57-year-old, genotype 1, which is not typically associated with fatty liver. And we had two biopsies 5 years apart. This is the first one. This is 5 years later. Stage 1 fibrosis with noticeable amount of fat. 5 years later, he developed cirrhosis. This was an example that taught us that having two diseases makes the disease progress much faster than hepatitis C alone. And there are some data to support this. This is an Italian data that show that if you have more steatosis, grade 3 to 4, then you're more likely to have higher stages of fibrosis, bearing out the case that I just showed to you. So those are some of the subpopulations that I think can be called a special population. So I come back to the CDC recommendation for outside the birth cohort. The current or past injection drug use, we talked about this with the resurgence of injection drug use in the younger population. Medical conditions that have high prevalence of HCV, clotting factor concentrates, this is well known. Long-term hemodialysis we've talked about, and this is a unique population where direct RNA testing may be reasonable. Persistently abnormal ALT, we just talked about this, that these patients have high levels of high prevalence of hepatitis C, but also they are at risk of high progression of liver disease, so poor outcome, at risk of poor outcome. We didn't talk about too much about HIV, but again, this is a high prevalence, poor outcome situation. Transfusion organ transplant recipients is well known, and then their healthcare exposure, and then children born to HCV positive women. So I think I covered most of the special situations, but I'm happy to take any questions that you have.
Okay, this presentation is also open for questions. Ray, you had mentioned that you showed a little bit of data about the state correctional facilities, and I think the testing is very variable across states. I think they have some inherent bias in not really wanting to know what the extent of the problem is. How are we going to overcome that, or are there any moves afoot to try to recommend that states where you're dealing with very high-risk populations overall change their policies?
I do not know the answer to that. I'm inherently skeptical about that issue. I think that the data are more pessimistic than what currently goes on because they reported states that had systemic, reliable reporting structure. So that's only 12 states. But I know out of California that there are county-level jails and other situations where they do test for hepatitis C. So I think that the testing is going on more than the data suggests, but I don't think there's a systemic process that's going on. Maybe Dr. Edlin has some comment about that.
Right. I think that's a really important point, and it's a really critical one, and there's a really opportunity there to achieve major public health gains fairly easily, but that opportunity is almost universally squandered. A lot of it has to do with the separation between in governments between correctional departments, as they're called, and health departments. And I think health departments have the opportunity to try to bridge that gap and to develop collaborations, and that's what happens in states like New York and California, where there is more testing and a little bit more treatment. But I think that's a really important problem that exists that really requires intervention by public health to try to bridge that gap.
May I ask a question? Ray, the data on antibody negativity in dialysis patients is we've known for a while, but it's really striking to hear it again at 22%. What about other immunosuppressed patients? And the obvious group is HIV infected. What's the frequency of false negative antibody testing there?
I don't know the exact percentage to that. I look for the data, but as far as I know, that the false negative rate is not high enough to go directly to RNA testing. I think that the antibody testing is sensitive enough. Recently, I think that's the first step to go, but I don't know. I don't do HIV too often, so I don't know if there are people who are more familiar with the situation.
Ray, do we know if knowledge of hepatitis C status actually changes behavior for the general population, but also specifically for inmates?
Knowledge of hepatitis C changes their behavior.
And therefore the risk of transmission.
I'm not familiar with the data, but based on my patients in my practice, I doubt that makes a big difference.
Well, thank you. All right, if you'll take a seat with the rest of the panel, we'll move forward. It's my pleasure to introduce the last speaker of this section, Dr. Scott Holmberg, who's the Chief of the Epidemiology and Surveillance of the Division of Viral Hepatitis at the CDC. Dr. Holmberg?
Thank you. I'm also going to give a very practical talk, I hope, on national surveillance for hepatitis C. I think sometimes people are focused on one or another function of surveillance, but I think we need to remember that surveillance for hepatitis requires us, A, to detect outbreaks, B, to measure the burden of disease, C, to target groups needing public health and medical intervention, and to evaluate the impact of prevention and intervention. Now, apologies if this is somewhat remedial to some of you in the audience, but I think we all need to have a clear understanding of how our national notifiable disease surveillance system, which is here, works, which is that the clinician, clinic, or hospital will send a serum sample. Usually, these will go to a commercial laboratory, sometimes to a hospital laboratory and sometimes to a public health laboratory, who will then provide the test results, usually electronically, and almost always just a hepatitis C antibody test result that only has the date of birth and the gender of the patient on it as it flows through. Only half the time will we get confirmatory NAT testing on top of that. These data then go to local and state health departments, which may be getting more information from the various reporters, but often are stressed with trying to figure out whether what's being reported is chronic, acute, or resolved infection. And you've got to remember that many of these state health departments have zero or very limited funding to do so. They then put this electronic data through the NNDSS, which then processes the data to give to us here in the Division of Viral Hepatitis, in which case we produce surveillance reports, and then, of course, we analyze the data for public health and other research purposes. Okay, so the situation, and again, these are all very practical considerations, and I thank Leslie Miller for pointing out some of them at the very ground level. So what happens is that our reporting sites are overwhelmed by the number of positive results coming to them. So only 30 of them in 2014 reported chronic hepatitis C cases to CDC. And again, these are tens of thousands of cases. And only 42 states reported acute HCV infections in 2014. And I don't want to, just to get back at this just a little bit, it's very difficult. I mean, we know that we're missing an enormous number of acute cases, simply because 80% of them are asymptomatic. And we also know that in order to actually have the capacity to distinguish chronic, resolved, and acute cases, you typically would need to go through 4 lab results, call 4 people, review 4 records, on average, sometimes more. This is time-consuming, and it's difficult. I'm going to talk about our acute case definition, and then we'll transition to what these acute cases are. Remember that our case definition is very stringent, and there's a reason we do this. We require either, essentially either jaundice or an elevated serum ALT level above 200. And I'm going to come back to this issue in a little bit. And then, of course, you need to be positive for your antibody, positive for your NAT testing. In dialysis clinics, as you heard from Ray, sometimes we get a negative HCV antibody seroconversion to a positive test. So looking at these red-hot, rock-solid, acute HCV cases over the years, we've seen an evident decline in the early part of the century, with the plateauing of cases. And then since about 2011 or so, we've seen a more than twofold increase in the number of acute cases being reported to CDC. We think these 2,200 cases or so that have been reported in 2013 and 14 represent roughly 30,000 estimated acute HCV cases. Now, so although these data are limited, they haven't allowed us to actually look at where acute cases are occurring, and we're seeing a real mushrooming of cases, as I think many in the audience know, here in the Appalachian states, rural areas of Midwestern states, areas of New England, Florida, and elsewhere. But essentially, you can see in this next slide that there are when you put the two together, there's a real accumulation of cases here in, again, these rural counties of Appalachia. Okay, so now we can move to how do laboratory analyses support our surveillance and epidemiology of HCV here? And I'm going to go through each of these one by one. First of all, let me point out that because our NNDSS system is full of holes and flawed, we rely on many other different data sets in order to piece together what we think is happening on a national basis. So you see here we fund some sites to do more aggressive surveillance. We do the NHANES study, which is about 5,000 U.S. residents every year who are randomly selected, who undergo both testing and extensive interview. And then there's some other studies here that some of you may be familiar with, but I don't have time to go into. So let's start with number one. How does it help us detect outbreaks? In the past, we've been able to use phylogenetic analysis by our excellent laboratory in order to match up serum samples, specimens from cases that are occurring in the same area, and enabling us to look at sources of infection when it's a clinic, or networks of infection when it's a community-based problem. The global hepatitis outbreak and surveillance technology, which you're going to hear about more, I believe, much more tomorrow in a session, is the current advanced medical detection technique, which allows us to look at many different quasi-species and link them up. But there are problems here in using these. Yes, we can use them and they help us look retrospectively at what's happening, because we have unavoidable delays in getting this information to CDC, delays in figuring out what's acute and chronic cases, submission of data and processing through NNDSS, identification and location of actual serum specimens for testing. So I think this is, as we improve here in speeding up the process, we're going to be able to use these techniques better, more and more. And then I don't want to belabor this. Our laboratory also does all the testing for NHANES, and this is critical because this allows us to tell the nation what we think is happening in terms of the actual number of prevalent cases we have. One can see, looking at antibody, that this has been declining over the successive years of the NHANES, as has HCV RNA. But we think taking these 2.7 million from the NHANES and adjusting for incarcerated people and homeless people, that we think there are about 3.4 million HCV infected U.S. residents. And then this is one of the, I think, the best uses of the ghost analysis. And I've got to run through this because I'm running out of time. But in this big outbreak of HIV and HCV in southwestern Indiana, analysis of a few hundred specimens showed a clear clustering of quasi-species in a large network here in the center. And so when we're planning what we're going to do in terms of intervention, getting people identified, into treatment, et cetera, we look at different treatment strategies. Do we want to have a hospital-based strategy, storefronts, snowball recruitment, et cetera, et cetera? So as a practical matter, we want to actually focus on this large group of people here who seem all to be connected. So in summary, we think there are about 3.5 million chronic hepatitis C and 30,000 acute HCV cases occurring every year. There are limits to laboratory surveillance collaborations right now. I think that it'll improve, I hope, in the future. Surveillance captures results, that is data from laboratories, but we don't actually get specimens. We don't actually have access to those. Surveillance detects chronic HCV years after infection, and acute HCV, usually an outbreak when they do occur, at best usually more than 4 months after these infections have occurred. I think there's a widely recognized need for laboratory methods to distinguish acute from chronic HCV. I know we've all been thinking about this for many years. It's been an elusive target. And can we get better access to frontline testing? In the meantime, and I just wanted to throw this out as a thought, I mean, if we're going to be doing reflex HCV testing, I'm wondering whether it might be worthwhile to do reflex ALT testing at the same time. Because if we know, remember the case definition, if we know the ALT is above 200, is a strong indicator of acute infection, this might actually help us do a much better job separating out what's going on. So as more and more laboratories do reflex testing, I throw this out as a thought, and I just wanted to thank you for your attention.
Thank you, Dr. Holmberg, for your presentation. We're actually, miraculously, pretty much right on time, but only if we fold Dr. Holmberg's individual question time into that of the rest of the panel. So we'll start with that, and in fact, we do have one gentleman standing there, but before we take your question, maybe we'll take Dr. Holmberg's question that he just posed at the end of his presentation about whether or not reflex testing should move beyond just looking at HCV RNA, but also should include other laboratory tests. And maybe we'll throw that open to the panel to collect their thoughts on it, and then we'll go to the gentleman at the microphone.
So I think it's a really interesting idea. I'd say from our perspective in a clinical setting, most patients who are getting antibody tested sort of have that lab panel done regularly, so I think that's readily accessible, but certainly an interesting thing to think about for patients outside of the clinical setting who may be tested, say, in a substance abuse treatment program or somewhere where they're not getting regular chemistry panels.
I'll also just comment. I think in clinical practice also, we do see I couldn't tell you the exact number, but a substantial number of patients whose ALTs are greater than 200 because they often have multiple other liver comorbidities. So I think you might overestimate that the number of acute infections like that. And, yeah.
Everything we measure is, I always say, index.
Yeah. Yeah.
We know that we would overestimate. We have to then adjust results back for exactly that. But at least if we have that data, we can analyze it.
Go ahead.
Hi, Ray Ahmed, Orshore Technologies. I have a quick question. Knowing that about 50% of antibody positives don't get confirmatory testing, and then states also having rapid testing programs, how do you incorporate that into your estimated annual acute incidence rate?
Well, the states and the big cities are reporting rock-solid acute cases to us. And what you saw in that graph in which they increased, those are confirmed. That's why we have a stringent case definition, because those are absolutely confirmed cases that we can hang our hat on. And then we can extrapolate from those to what's going on.
Could you turn your mic on?
Not everything, I'm sorry. Oh, sorry. Not all things reported to us are just a singleton antibody positivity. I mean, we do get more information, and there's certain states and public health departments that do really a terrific job trying to weed things out. So we use that information as we move along.
So, like with say the enhanced surveillance states, do you kind of use that?
Yeah, exactly.
And then extrapolate that for the rest of the country?
Right, exactly. Thank you. That's exactly why we fund some places to do better surveillance, because it gives us more complete information, particularly about things like risk factors, demographics, where they live, et cetera. So the states that we fund, on the whole, do a much better job in terms of analyzing and reporting to us.
If I can have a quick follow-up. With all the caveats about the system, but if the idea of acute case discovery is who's come in contact with the virus, then isn't the antibody testing the right tool to use instead of the RNA?
Well, it's a critical sine qua non of testing. You have to screen, and you must have the positive antibody test. But as we know, the large, only 80% of them are still chronically infected, right. And et cetera. So, yeah, no, you have to have the antibody screening usually. I mean, no one starts with NAT testing. So,
John,
just to stay on surveillance for a moment, and some considerations of changes in surveillance. One that we've talked a bit about is the need for a perinatal case definition because of the increasing number of women of childbearing age who are Hep C infected, and we are seeing increases of that being reported on birth certificates. And then secondly, and there's 2 states that are about to adopt this process or already have done so, is expanding surveillance to collect information of all HCV tests so that you could actually identify seroconversions more readily through developing a registry. You could have a marker for viral clearance, and you could also have a marker for reinfection to help you get on that leading edge of transmission. So I didn't know if you had some thoughts about that, Scott, but also encouraging our colleagues from Tennessee and Kentucky to comment on that, please.
You can actually press the microphone on your desk also and use that if you'd like.
Thank you. Carolyn Wester from the Tennessee Department of Health. So exactly along the lines of thinking how we would start to build a statewide continuum of care, much like we have for HIV. So although chronic Hep C is not officially reportable in Tennessee until January 1st, 2017, this past January, we changed laboratory reporting requirements so that we would kind of phase in and not make all the clinicians nervous until next January. But one of the elements that we required, in addition to obviously all antibody positives and RNA positives and antigens, should and when those become available, but negative antigens and also negative RNAs, so that we could start building not only who was confirmed as in a positive test, but who got a confirmatory test, and then start building a strategy for how we would, in a longitudinal fashion, determine who had cleared and even perhaps relapsed or become reinfected. One thing that I also thought of when you were mentioning the possibility of reflex ALT testing to discern or be a trigger for investigation for acute cases. We have not done that, but with some supplemental funding in 3 metro sites and health departments where we're conducting antibody testing among young reproductive age men and women, we are, in addition to asking risk factors, right up front asking questions about symptoms. I realize that a large number of clients The mass majority are going to be asymptomatic, but at least that's information that the health department will then have in hand if and when the antibody and RNA test comes back positive.
So Doug Thurlman from Kentucky. I'm a CDC career epidemiology field officer there, but also serving as a state epidemiologist right now because we don't have a division director and haven't for a while. So in Kentucky, we have changed our legislation, so we're going to mandate all hepatitis C and B testing will be reportable regardless of the result starting October 1st. I don't think we're going to be getting in those results that quickly because it's lab reporting only. So we're not like Tennessee. We're not asking the clinicians to do reportable disease reporting on that. So I think we're going to have about 12 out of 120 facilities who are able to report by October 1st, but the others should be online within the next year or so. So very similar to Tennessee, we don't have our strategy all worked out about what we're going to do with all that data when it starts coming in, and we'll be working on that. We just wanted to get up front and start doing that because hepatitis C is such a huge issue for us. It's the primary priority issue in Kentucky for infectious disease right now. So
I'll just use the prerogative of the moderator to mention the project we're doing here in Chicago, which is that with funding from the CDC, we have a project called HepCAT, the Hepatitis C Community Alliance to Test and Treat. And what we're attempting to do is to link together multiple electronic sources of data. And so we're bringing in EMR data as well as the data that is gathered through pharmacies, in our case Walgreens being the lead, but also another BioCure, and then linking that to laboratory databases as well as public health database, so that way we can, through a more passive system that doesn't require quite the level of activity to input all that data together. It comes through and goes into a registry. We've now linked 10 organizations through their EMR into that system and are looking to increase more. And through one of the Medical Studies Acts in Illinois, we've now will soon begin to collect the negatives as well as collecting the positives in hopes of allowing us to be able to do a better job with collecting incidence and prevalence data.
Yes. Very patient. Thank you.
Thank you. Jeff Engel from the Council of State and Territorial Epidemiologists here in Atlanta. So the state epidemiologists as a family have had hepatitis C as a priority, at least a presidential priority for the last 2 years, and feel that the whole surveillance scope is horribly underfunded, as I know you do too, Scott. And the 7 enhanced states, the family of state epidemiologists view that as core surveillance, not enhanced. Every state should have that capacity. And the fact that this is so badly underfunded is not going to be made up with electronic laboratory reporting, because ELR reports contain very little epi, if any, epi data at all. You're lucky to get the provider name on the ELR report. So although it's an important beginning, it's not going to be the fix that's needed, which is really a hepatitis C coordinator in every state. So that's a comment, but my question is really to Dr. Miller, if I may. I'm really interested in the pedagogy around this, and you describe a rather typical academic internal medicine setting, and I'm an internist, so I get that. But what are you doing in terms of interprofessional education, particularly in the nursing community, the pharmacy community, and in family medicine? Thanks.
Sure. So that's a great question, and I'd say we haven't reached out to those other communities yet, but we are doing a lot in terms of trying to train other primary care providers to do this. And so I've done a lot of work personally just to give you a real world example. So a group, a nurse-run indigent clinic in Savannah, and they wanted to follow the CDC guidelines and start to screen, but they realized, they were finding a lot of positive patients and apparently no access to gastroenterology or hepatology for uninsured patients in Savannah. And so they reached out to me and said, we want to learn how to treat this, but we think that's, not feasible. And I said, absolutely, you can learn how to treat this. And so we worked together, shared algorithms, they developed a program, and now have a really active treatment program. And so we're trying to develop sort of trainings, and then we went down to Savannah and actually did a training for all FQHC providers there. So kind of on a small scale, but building up, trying to build the primary care capacity to do it. And I think the biggest message is that it's doable. It's absolutely learnable. We sort of have new faculty start, and within a couple months, they're up to speed and treating on their own. So I think spreading that model that it's absolutely possible in primary care is really powerful.
May I add to that? You didn't mention pharmacists. So the St. Louis VA is the VA that has treated the largest number of patients with hepatitis C of any VA in the nation, and they rely on pharmacists to do this. They have one part-time hepatologist and a physician assistant who does some initial evaluation of the patients, but then it's turned over to the pharmacists, and they've been very effectively trained to manage this.
Well, thank you. In the interest of staying on time, okay, one more? Okay, one more.
Good morning, Steve Coe, Boston University, ex-CDC. Ray, that was a very nice talk, and I wonder if you would give some thoughts in terms of maternal-child transmission of pediatric patients in special populations, especially with your paradigm of high prevalence, also diagnostic issues, and then the third one of outcomes. I think it's a very interesting issue, especially with maternal antibodies up to 18 months, and then even the issue of ALT sometimes being a marker for higher clearance. So wonder what you think other thoughts might be well received.
Clearly you thought more about this than I have. I'm an adult hepatologist. I know very little about kids, but except my own, I hope. But all I will say is that that used not matter too much because the baby boomer is where hepatitis C used to be, but now with the resurgence of acute C cases in a childbearing age, I think it's become a more important issue. I don't deal with it on my day-to-day basis practice, so maybe I refer to Dan if you have some ideas about that.
Well, I wish I had some great ideas, but I can just say the following, that at first it's about awareness. Pediatricians are quite malleable and are quite willing to do what's needed, so it's a question of knowledge and awareness. And there just isn't a broad base of awareness among those that take care of children of how important this has become. It's always shocking to them that hepatitis C is growing at a rate faster in that population than any other. And so I think one of the simplest things we can do is make this a point of conversation with our colleagues.
I wanted to just quickly comment. Welcome back, Steve. As John pointed out, one of the reasons we need a good infant case definition for hepatitis C is because we're looking at these data now from a number of sources, both NNDSS, from Quest laboratory testing, et cetera. And we think that with the concomitant with the rise in acute hepatitis C in younger people all around the country, we're also seeing a rise in HCV-infected pregnant women. We have an analysis right now. First of all, there was a recent report in MMWR just from a few weeks ago, and for those who are interested, look back, you can see the absolute increase, doubling of the numbers of estimated women of reproductive age who are infected. We're doing an analysis which suggests to us that 28,000 HCV-infected women are giving birth every year to roughly 1,700 infants who are infected. So this gives a certain urgency to coming up with this case definition. And thank you for bringing it up because it really is a poser in terms of trying to figure out what the definition should be, at what point antibody positivity, at what point NAT positivity. So it's one of the big issues that's, we think, coming up in the near future. And thank you for raising it.
So I want to thank the panel for their time. We're actually a little bit beyond time right now. I think all of you did a fantastic job of getting this conference off to an excellent start, and they definitely deserve another round of applause.